Good day to all of you. It's an honor for me to be able to present our experience here and care series here in this very extraordinary event. So thank you for having me here. My name is Bhuwana Putra. I'm from Sanglah General Hospital, Bali, Indonesia. So what I'm going to present is actually a very simple topic about our initial experience in actually ICP monitor for severe TBI cases in Bali. So what we're going to discuss about today is actually I'm going to go over with some basic knowledge about ICP that we already know, and we're going to see what are the types of intracranial pressure monitoring that is being used, more sophisticated one, and so we can compare it with what our experience here in Bali. So as for the introduction, so this is severe TBI cases, as we know, comprise of about 5 million cases per year all over the world, and a lot of these kind of cases actually happen in the low middle income country as here in Indonesia. And intracranial hypertension is found to be like about 40% to 60% of all severe TBI, and as one of the major factor of death in all cases with severe TBI. And one of main possible management target, as we know, is the ICP control. So we really have to control the ICP in managing patient with severe TBI. And how to know the ICP, of course, with ICP monitor. And the proportion of ICP recording greater than 20 millimeter mercury is actually highly significant in predicting outcome of the patient with severe TBI. And just a little quick overview about the ICP monitor. ICP waveform, actually the ICP is, if we are going to monitor the ICP, then we actually have to consider the ICP waveform, as we can see here, which is already being described by Lombok. There's actually they describe that there's three types of ICP wave, as we can see here in the diagram, which we can interpret that the patient is actually having just a normal waveform with perhaps a cerebrovascular and periodic breathing rhythm, or if the patient is actually really having a high intracranial pressure. And this is just several types of ICP monitoring placement that can be done, from the sophisticated one until the very simple one. The one that is considered as still of the one of the gold standard for ICP monitor is actually still the intraventricular device that is coupled with a pressure transducer. So if we do it without the pressure transducer to the monitor, then might be a less of the gold standard. And as we see here, this is the pros and cons of putting the ventricular catheter. And as we can see here, the negative side of putting the ICP monitor intraventricular is actually there's a risk of misplacement, especially that we know that we use the more freehand technique, and the range of rate of malposition is actually from 4% to 20%, which further can cause a increase in risk of hemorrhage, which can happen with less than 2%. With a risk of obstruction, even though that we already put the ventricular drainage correctly, there's always a risk of obstruction after the placement of the ICP monitor into the ventricular system. Risk of infection is actually less than 10% and increase after 5 days. So that is actually one of consideration as to how long we should put the ventricular catheter in place. In the positive side, it is actually relatively cheaper than any other kind of monitor, the ventricular monitor, and it actually considered as the one of the most accurate among all of the other types of monitor, and it can measure overall ICP instead of just regional or local ICP. And also the biggest advantage so far for using the ICP monitor intraventricularly is actually the ability to drain the CSF as a measurement to decrease the ICP. As we can see here, this is actually a simple diagram about the procedure of the ICP monitor, and the picture on the right side is here we can see that the one that is the standard of the ICP monitor actually should comprise of the transducer to the monitor, so we can see the ICP waveform, and we can evaluate the ICP continuously rather than just see it intermittently about the amount of ICP. And then we can also drain the ICP to drain the CSF to the reservoir, and then we can take the CSF as sample for further evaluation. And this is our study and our experience series about the custom-made ICP monitor that we use here in Bali as the part of management of the severe TBI. And indication of putting the ICP monitor itself, actually this is quite the same as the indication that is in the guideline of the Brown Thermal Foundation. So all the patients with AGCS at 3 or 8, salvageable patient. And with our normal CT scan, that is not really an indication for the surgical, like decompressive or maybe evacuation of the mass lesion. Then we put the ICP monitor. So this is the simple tools that we use. A lot of time we use the manual cranial drill. Sometimes we have the privilege to use the automatic drill. And just as you can see, just a standard set of neurological set that we use in daily basis. And the procedure itself is very standard that we already know. So we use the core point as the place of insertion of the ICP monitor and put it in the frontal horn, the lateral ventricle, and usually we use the nasogastric tube as we can see here. So it's very simple that we can do it everywhere. Nasogastric tube with the number is like number 10 or perhaps number 8. Depends on the condition of the patient, on the availability of the NG tube itself. And sometimes we have the privilege of using the extraventricular drainage to be used as ICP monitor, and then we just modified it a little bit so we can use it as the. So as we can see here, it's actually a very simple setup. After we put the ICP monitor, then we can set this up in the ICU or wherever we take the patient to. And this is a very simple setup. As we can see here, that there's two setup. One is actually going to be the ICP monitor setup, and one is actually the EVD setup to drain the CSF if there's any increase of intracranial pressure. And in the middle picture, as we can see here, there's a reservoir, the urobag, and the just being put in the side of the patient. And there's actually a three-way. One is connected to the intracranial pressure system, ICP monitor system, and one is connected to the extraventricular drainage system. So first we put the system into the ICP monitor system. If the CSF is actually, or the ICP is actually getting higher than 22 millimeter mercury, then we can put the system into the extraventricular drainage and then drain the CSF into the urobag. So it's actually a very simple system without any monitor or any kind of transducer. The point being here is actually one of the problem is that we cannot see the ICP. We cannot evaluate the ICP continuously. We cannot evaluate any kind of waveform and anything. It's just a really simple setup that really helps us in managing patients with severe TBI. So this is the result of some of our patients. Actually, there's a certain patient here that is included in this study. With various kind of intracranial lesion going on, one with brainstem hemorrhage, one with intracerebral hemorrhage in the corpus callosum, and most with severe diffuse injury, and with GCS actually all lower than 8 in this case. And this is the result of our study and our series or mini series here. So this is all the study. Length of stay is so a lot of the patient is actually not managed to survive. Some patients actually survive. I mean, if they survive, they're going to have a real long treatment, as we can see here, with the initial ICP, some with a really high ICP, some with just a not little to normal ICP, with complication. There are actually two complication, hemorrhage complication, and unfortunately no infection as per this last patient. And this is intraoperative bleeding and duration of operation is seen as in the operative report. And this is the summary of our finding. With the mean operative time is about 43 minutes, and mean operative bleeding, intraoperative bleeding is actually only 5 cc, and mean initial ICP is about 19 centimeter water, and average length of stay is about 60 days. So some ways are really long length of stay in the hospital. Well, with a complication of hemorrhage in 2 patients and fatality no infection. And the problem is when using this kind of custom-made ICP monitor, being a relatively cheap option for as a ICP monitor, it is actually really difficult to evaluate the ICP continuously. So all we can do is actually just evaluate the ICP intermittently, and one point of evaluation instead of ICP trend, as we know that we should actually able to see the ICP trend instead of just seeing it at one time to the other time. And evaluation of ICP waveform is really not possible using this kind of method. But this is actually this really simple procedure with just basic equipment. So without any kind of sophisticated method of putting the ICP monitor without, and several limitations that we have to admit regarding the evolution of ICP, that we cannot really appreciate any kind of trend of ICP or any kind of waveform of ICP, that we only able to evaluate the ICP intermittently, but still it is a relatively safe and reliable method to objectively measure the ICP. And adaptation and modification with being used here in our place with the absence of any kind of advanced ICP monitor. So thank you very much once again for having me. Wish you all a good day and good health. Thank you.